All right, welcome back to another PCBH Corner. I'm super excited. We're going to have a fun one today, and joined by two esteemed colleagues who actually, Nancy, we weren't even talking about this. I have had very kind of little interaction with you all, so I'm really excited just that this moment, not only learning and hearing about you, but just getting to know you all and having some fun. So Nancy Ruddy and Susan McDaniel, which I think everybody is very familiar with, and they just put out a great book, Systematic Approach to Behavioral Healthcare Integration. And I love this second part of this, Context Matters, which obviously we could get down with for years and for decades. So that's where I just am really excited about this PCBH quarter. So to start it off, I wanted, as always, to do kind of introductions. I don't think you all need introductions, but maybe just who you are, where you're at right now, and I would also one of the things that Nancy and I were talking off screen that I really appreciate, that we're going to try to have this PCBH corner be about being pragmatic and really talking about ins and outs and having a rich conversation with that. So let's get into it. Susan, I'll start with you. Do you want to give kind of a introduction, who you are and where you're at right now?
Uh, well, it's a pleasure to be here. Thanks for inviting us, David. I'm Susan McDaniel. I live in Rochester, New York, which shockingly, I've been here since 1980, after I finished my fellowship in Texas. So I'm a Southern girl, and somehow I reverse immigrated, and we were supposed to be here for 2 years, but that's what happens. I work at the University of Rochester Medical Center, where I've been since '82. And I think it's such a good match for what I care about, because this is where George Engel developed the biopsychosocial approach, which still permeates the school, fortunately for me. And also where Lyman Wynn had been chair, who was one of the people who helped start family therapy. So my work really is a combination of the two of those people's work, informed by many great talented colleagues thereafter, like Dr. Ruddy. At this point in time, having been here for so long, I have several different things that I do. I am the director of the Institute for the Family, which I've been since 1996. I'm also chief psychologist of the Department of Psychiatry. I am the vice chair of family medicine, which is where I started and where I've been all along. And if you stay there long enough, they make you vice chair. And then I also, more recently, meaning in the last 12 years, started a physician faculty communication coaching program for the medical center. So that's my latest endeavor, and it's quite fascinating.
So you didn't want to say anything about being past president of APA? That
Oh,
wasn't.
well, I mean, I've been lucky enough to be active in a number of organizations, including helping start the Collaborative Family Healthcare Association. I actually was more involved in a lot of systems and family stuff earlier in my career. And then as healthcare reform was beginning to happen, people encouraged me to run, and for American Psychological Association president, which I did, and a little bit as an outsider, but I won, and so then all that happened. So yes, I did have that leadership role, which has been very helpful. The communication coaching program really is a leadership development program. So I learned a lot about leadership in that experience.
Hell yeah. Hell yeah. Well said. Nancy. Nancy.
Well, as you can imagine, when your mentor doesn't even mention, "Oh, yeah, I was president of APA," you have a little bit of, like, total slackerdom feeling when you
That's
work
what I was
in
thinking. I
your
was like,
30
man, if that's
years.
not like the highlight, like, good God.
I know, I know. Oh, yeah, I did that too.
Yeah,
It's most people's lead in, but for Susan, it's just kind of anyway. No. So, I started out at University of Rochester with one Susan McDaniel. I call it the fateful call, where she called me. I was gonna be a child psychologist in private practice, and thanks to
Oh.
Susan, I went this totally different direction. I had no intention of working in a medical setting, and, started out at U of R in the family medicine department, we ended up moving around a fair amount. My husband's an industrial psychologist, and so he worked in corporate America, which that always means that you move around. And because of that, I stayed in academic medicine and family medicine residencies and so on, and had a few off ramps from primary care. But in general, I've been working in academic medicine most of my career. And then a few years ago, I pivoted to teaching doctoral candidates in psychology. So I'm currently core faculty at Antioch University in New Hampshire. Sandy Blunt started our program, and he had the good grace to retire when I was moving back east from California. And now I'm also in the process of doing some work for University of Maine. And so I'm going to be doing some work with them going forward. So beautiful Acadia here behind me. I live in Portland, Maine. I adore Maine after 18 years in New Jersey. No offense to Jerseyans, but not for me. And so just has been a kind of a wild ride. But now I'm teaching doctoral folks, and it's really interesting how it's similar, how it's different from teaching in academic medicine. I miss primary care. I'm not working in primary care right now. And every time I see it, I'm like, "Oh, that's my home." But I feel like this is the work kind of where we're at right now, right? Pipeline, getting people ready to do this work, helping people understand how it's different, helping people understand how there's skill transfer. So that was also part of why we wrote this book. We felt like it was a way to get people to think about, as we were talking about off camera before this, the complexity, but the joy of this work and how it's not easy. It's not like something you're going to just make happen easily in any system. But if you get there or you get closer to something that's more integrated, it's just incredibly fun work to be part of a team. And I believe to the soles of my feet, it's just a better way to be helpful to people work with those people that we're there to serve. So it
Oh
was fun,
yeah.
to do this together.
Yeah, that's awesome about Maine. So I did my undergrad at the University of Albany. I played basketball there, so we would make trips up to the University of Maine to play them every year. So fun time, a beautiful
They
place.
still have the same field house.
Yeah, that's the thing. We went up during the winter, so it might not have been the best time to make it to Maine. But hey, what are you gonna do? So let me ask you
Maine does
that.
not complain us. We don't worry about the weather.
I like that. I like that. So let me ask you all this. That's a really great jumping off point, Nancy, is that, for those who haven't read the book, I would very, very much encourage it. And Susan, I was talking to Nancy before joining about how the book is incredibly comprehensive while not being overwhelming, and talking about the different types of factors that go in. And we also talked about this idea of it makes it seem doable, but not easy. That it talks about the realities of, like, hey, this is a leadership thing. This is a training thing. This is a clinician thing. This is a systems thing. This is, a variety of different aspects of that. So first question for you all is that what was your hope with writing the book? If you did, you all think about, hey, if this book is successful, after someone reads this, what were you hoping that they experience? What was the main thing that really inspired writing this book?
Well, I'll start and then Nancy can really fill it out. So this was Nancy's idea, and she, in her charming way, bugged me about it quite a bit. And I think over a glass of wine, that probably helped things. But the reason I was compelled to do it, and I realized immediately that she was right, was that this just providing a systemic overview for what the situation is when you try to integrate healthcare. It just wasn't out there. It's out there in these little bits and pieces, but it's not like, here's the story if you really want to be successful. You can bring your favorite flavor of integrated care, psychology, psychiatry, collaborative care, PCBH. You can do all of that, but you have to also think in a larger way about what the various systems are. If you want to really be successful, you need to bring some implementation science to it. You need to understand change management. As you said, I mean, it's like being a human. It's not easy, but it's doable, but it's better to know what the deal is than to think, if I just figure out what, gastric reflux means, then I can be an integrated care clinician. And especially if you're in a position where you're trying to institute the integrated care. But even beyond that, understanding there are multiple things that affect the situation. There have been places recently, big places in Boston, who suddenly are not doing integrated care. What happened? It wasn't because the clinicians didn't know how to do it. It wasn't because physicians weren't satisfied or patients weren't satisfied. That's not why the thing fell apart. So you want to build the systems in a way that can be as solid as possible, and bringing a systemic lens to the situation of integrated care. I think there's a lot of illness focused or behavior change focused stuff out there, but not this. And so I realized, as is often true, Nancy was right. And so I did what she said.
Nancy, where's your mind going?
Well, I mean, I think all that's true. For me, this kind of bubbled up from kind of a lifelong experiences of leaving Rochester, being in New Jersey for 18 years. When I moved there, New Jersey was 50th out of 50 states for levels of integration. A lot of tears were shed at the Ruddy household for this, honestly. I couldn't find a way in. And a whole confluence of factors. There was a nonprofit called Nicholson Foundation. They brought in Cherokee. Cherokee brought in me. We all worked together to try to move the needle. And I'm happy to say Rutgers just got a huge integration grant. They have Healthy Steps now. I mean, it was a kind of turning point moment of many, many people working together. And when I read, when I was doing implementation work, I started reading what was out there. And it just felt a little cookbooky, quite frankly. And not to be critical of, I mean, but I think that's where we start, right? We start with here's the elements, but how much of this and how much of that? And I felt like it didn't capture the complexity of implementation. I also felt like, and I am a huge proponent of CBT and motivational interviewing, but I also feel like if you're not working with the family and embedding and thinking about the context of the family when you're doing healthcare work, you have one hand tied behind your back. And so I felt again like there was just an opportunity. So part of the comprehensiveness of this came from the fact that first of all, we started writing about implementation, and then we started out writing about clinical. And I said, well, we can't write about this if we don't write about implementation.
Amen. Amen.
And then I said, oh, well, we can't talk about implementation unless we give it context and history. So fun side note, we wanted to have it be context matters exclamation point, but APA wouldn't let us do that. Like we don't do that in titles. So
Oh,
We do that in all our
true
presentations.
story. Yeah, we have it in all of our presentations. We're very clear. There's an exclamation point after that.
I will make sure to put that in the title.
There's an invisible
That's right.
mark on the book cover, but we like to make it visible anywhere else because it's a much simpler way to say what we're talking about.
Yeah.
If you've seen one integrated care clinic, you've seen one integrated care clinic. Why is that? And Carrie Stevens' studies show that, you have to work with what you have. And so anyway.
And Nancy, the thing that, you were saying there that I really want you to expand upon, and I think it's so profound about how, and again, grace, love, and compassion, we almost needed this as a field as far as having it be like a recipe kind of aspect. And Bridget's talked about this a lot. It's like, we don't necessarily want cooks, we want chefs, right? Like we want people that are able to understand what it's not, hey, you do this because of this, but you understand why you're doing this. And I love how you said that, hey, we started as a clinical book, but really it didn't make sense to talk about clinical stuff if we didn't talk about these other things. And then it didn't make sense to talk about these things if we don't talk about these. And that's a rare thing in integrated care about these different levels where it's just like, oh, just teach the BHC to do brief therapy. It's like, that shit ain't gonna work. Right. If there isn't these other things. Yeah. Any other way that got me hyped how you were saying it. Anything else your mind was going to with it?
Well, and I would be remiss not to mention that my husband is an IO psychologist, right? And so he does organizational change. He does leadership training. Susan's worked with Eduardo Salas, who also does amazing work in leadership. And so I think we were informed. And once again, I find it so fascinating that we're so hyped about working as a team when it comes to clinical work. But then when it comes to other parts of the work that we do, we tend to be solo providers. So the BHC is going to figure out the billing. No, they're not. And so it takes a village to create integration. It takes a village to provide integration. And so I think you mentioned about the complexity. I think we need to have a strategic approach to organizational change. And I think that's what we tried to capture. Susan used the word change management earlier. And that's really what we're talking about. Practice transformation is incredibly hard, right? We know that. We know that people want to keep doing what they're doing. They're running on their hamster wheel as fast as they can. And to say, oh, can you keep running on your hamster wheel as fast as you can and then do it differently? And people are like, nope, can't, gotta
Hmm.
keep going, And our payment systems, the larger system models, how we're trained, all of it flies in the face of where we say we're trying to go.
Amen.
So if you're going to make this happen, you've got to approach every person, every practice, every healthcare system, every legislator. You've got to approach people with an assessment of their readiness to change,
Mm,
their understanding, right? You've got to
mm,
be able to say to them, "Let me explain to you why I am your best friend right now. Let me explain to you how
mm,
the work we're going to do is going to make your life easier and is going to help people too as a
mm,
lovely side effect." And so I think that really at the end of the day, anyone trained in family therapy, you're trained to change
mm,
systems, but it's
mm.
taking a lot of those same family therapy skills and applying them to a different type of system. And I think sometimes people are uncomfortable with that. But I think both of us had the opportunity to learn from people who this is what they do, right? Is organizational transformation. And so I think that was a happy accident, something that came together for us as we were talking about it, but it did kind of become the ever expanding book, as you said. So it was during the pandemic. It was a fever dream. I'm just saying, like, it's like, I know we need this too. And Susan would be like, oh my God.
Well, what's really interesting about this, and this is why the book had many times that I prompted and reflected, and I emailed you both about, like, even, and I want to get into this and maybe in a later question about the training aspect, where it's like, oh yeah, hey, we're all talking about, and we all have worked in family medicine residencies, that it's like, hey, we'll have a behavioral health faculty member of the family medicine residency, but then when we switch it and we're like, oh, psychology internships or fellowships or other education programs for behavioral health. It's like, do we have that many medical providers? Like, do we have that many, like that was a big, like, and even how you all talked about didactics in different ways was a really interesting thing. The one thing though that I love, again, Nancy, that you were saying, and I think Bridget and I, we were talking about this as I was talking to her about the book. We probably got into consulting way too early. It's because we didn't know what the hell we were doing. And we would go into systems and we would just
None of
basically
us
tell them,
did.
yeah, right. Thank you, Susan. Yeah. And again, we would go into systems and just basically say, do this, rather than what you're saying, which is like, hey, do an assessment. Where are we at ready to change wise? Is this something that, like, do you even know what you want your integrated care to be about? Is it about just solely treating behavioral health? Do you want it to actually enhance primary care?
Well,
Like,
what is really
The mental model.
frustrating to you? Where are the pain points in the system? Because inevitably it's our territory. And then it's easy to say, we're really interested in that. That's something that we do.
it's applying a contextual approach to even setting up systems. So let me
Right.
ask you. So let me ask you actually a decontextual kind of thing. Over the years that you all have done this, what has been, in your mind, the biggest thing that we forget to check on, that we forget, as if we're behavioral health providers, are becoming very excited about coming into integrated care, coming into primary care, doing all these different things? That, what is the thing or things that people just, like, we forget to assess? Like, we don't talk about it, but it really, if we don't assess it, is going to cause us to go off the rails. Where does your all's minds go?
So I want to answer the first part of your question, and then I'm sure Nancy can answer the second part. Because where my mind first went, in terms of what I didn't expect to happen and think is important, just in terms of the attitude we come in with, is I didn't expect how much it was going to change me.
Whoa.
Like, I came because I'm the missionary and I'm gonna, convert the natives because Lord knows they need it. And that attitude is really, as my mother would have said, not very attractive. And it's amazing I kind of stumbled through some of those early experiences. But so I think recognizing, unless you have just really good primary care and health psychology training, along with your solid behavior change, psychotherapy, and every other thing we have to learn, unless you have all that in your graduate school and clinical training, which currently nobody does, then, really just understanding, being humble, and recognizing we have a huge amount to offer. I think what we offer fills some of the gaps that are significant in our healthcare system and why our healthcare system doesn't work. But that doesn't mean that we understand that, that we ourselves don't need to learn from the people that we're working with. So that's just an attitudinal thing that took a bit to learn, and that I think with the interns and fellows that we have, usually the first several months are challenging for them, because if they're a fellow, they just got their PhD, meaning they've learned everything they need to know, and now they want to share it with poor physicians. And it is sobering and disturbing to recognize, first of all, they're going to learn some stuff about systems theory, which usually they don't know. And secondly, sometimes the physicians know way more about their patients than they do, who are seeing them in therapy. So anyway, that was my first association with what you were saying. Now, the issue of, besides assessing yourself, so that could be one thing, and your self-awareness and humbleness. Now, Nancy can talk about all those systems that are easy to forget.
So I think one of the things, and we just need to own, we are 3 psychologists. So I've noticed we're using the term psychology, and this is not from psychology, right? So the humility of recognizing that many different fields have been working on this: nursing, social work, clinical mental health counseling, definitely couples and family therapy. And so I think that I want to name that. I think at the end of the day, we are remiss if in fact, psychology was kind of behind the curve, TBH, for a long time, until like James Bray and Susan McDaniel became president and kind of like pushed the institution. So I want to say that I think, there's you said about, humility and respectful curiosity. So approaching each system with respectful curiosity. What do you need? Tell me how we can be helpful. I mean, that is really the foundational process, just like it is when we're providing clinical care, right? So we want to address what's important to the people in the system. We want to be aware of the variety or variance in who's ready, who's not. I think one of the biggest things I see from BHCs is they tend to go in, they find those 1 or 2 medical providers who refer to them all the time, and then they kind of forget everybody else because everyone's in a little comfort zone. And then you've got 80% of the medical providers not using the integrated service because, nobody ever really talked to them about it. And so, you definitely, one of the things we talk about in the book is that idea of building continuums in your head of readiness to change, not only amongst providers, but amongst staff, amongst leaders, who understands this? I think another key thing that we forget to do is, and you alluded to this earlier, a shared mental model. Do we all agree what the mountaintop looks like? Because if we don't know where we're going, how are we going to get there? And to recognize not every system is going to look like a fully integrated system by our standards. All's good towards the good, right? So can we get closer? And that's why I love Carrie's work, because it talks about the elements, and you can say, here are things you're already doing that align with integration. Can we do those a little more? Right? It's easier to build from something people are already doing rather than introducing a new set of skills. And then once people see the change, and I think at the end of the day, for all the problems we have in healthcare, providers and most leaders care about outcomes. They want to see the people they serve do better. And I think that as we engage people who are maybe kind of 1 foot in, 1 foot out, more so than the people who are, all in, slowly over time, those folks have the experience of their patients getting better. Or having someone there in that moment of crisis when the person's like, what, puddle on the floor, and they don't know what to do. Those critical incidents move people forward. They go, oh my
Absolutely.
God, thank God you were there, right?
I have no idea what you did, but could you please
Exactly.
do some more of it?
Do
And
it
I
again.
think we're fortunate in that medical people in general do care about the outcome and understanding all of it, like psychologists love to do ad nauseum. That's not their thing. It's just like, I have no idea how you saw that in me or in the patient, but thank you.
I love that we're talking about outcomes, because that was another thing that I wanted to ask you all about that you talked about in your book. And simultaneously, as I was reading your book, I was reading Jessica Slider's book about little treatments, big effects, and this idea of trying to really provide more of a pragmatic clinical kind of application. And you all spell this out in your book as well, is that hey, the way that we do treatment is usually that we have academics and grace, love, and compassion, because that's needed, us finding these things that work. But basically, we're like, hey, this works. Now we're going to take it to the public and just say it works. Now you all need to do it, and you need to uptake that. And unfortunately, that hasn't necessarily rippled out. So,
And how
Susan,
dissemination works.
yeah, that, unfortunately, right? So,
Exactly.
Susan and Nancy, let me ask you all this, because you all, as you said, you work, you've either worked with students or you're working with students, and particularly, Susan, I love how you said, hey, you got a PhD, or they learned everything they need to know now, right? And then they
Yeah,
get
I
punched in the
used to know
face.
everything. Yeah.
Yeah. So, what is your approach for educators, or what's your suggestion for educators that are dealing with this reality of people are getting trained in grad school about, like, hey, treatment protocols, you got to do this, evidence-based treatments, all these different things. And then you go to try to go into primary care, and we make primary care almost something that it's not, in a lot of ways, nor do patients really uptake that. That's a challenge. Like, any suggestions for educators of facing that reality, and how to make sure that they have an engaging conversation with their trainees, and also it ripples out to what we want, which is more flexibility with how we're approaching patients?
I'm going to jump on this one. So,
Yeah.
transitioning into teaching doctoral candidates has been hard. My brain hurt really bad, and it was during the pandemic, so it was just terrible. But I recently had a conversation with a student that I think really captures this. So, part of the problem is when you are a student, when you're on shaky ground, you're not sure about what you're doing. We want to hang our hat on something, right? Like, oh, this protocol says do this. I'm going to do this because then I'm doing evidence-based practice. What I've tried to teach my students is how evidence-based practice and practice-based evidence help each other, support each other, and help you figure out if what you're doing is working. So we all know that the protocols work when someone's ready for them to work, right? So, I was reading students' notes, and it was like, uh, you know, X did not bring sleep lab to or sleep whatever today, and I'm like, 6 notes in a row, and I'm like, how's about we drop the idea of a sleep log right now because it's they're not doing it, you know. Um, so much of what I find is a really helpful approach with students is to be able to say, start with evidence-based practice. And about 30% of the time, it's going to work like a charm.
Mm.
About 30% of the time, you're going to need to back up and do some readiness to change work, to prepare the person to really be willing to move forward, right? There's so much approach avoidance in the work that we do. It's like, yeah, I want that to be different, but ooh, I'm safe where I am, right? And then 30% of the time, you're going to have people who have big T trauma, who have much more serious conditions that probably aren't appropriate to be treated in primary care, but we can be the bridge, right?
Mm.
We're going to be the ones who help prepare them essentially for starting to deal with these very painful things in their lives. So that's on the clinical side. And I just love the rule of the thirds. I think the same thing is true with all the different people you're going to work with. There are behavioral health people who are never ever going to transition to a primary care approach or a brief approach because they believe to the soles of their feet that if I don't see somebody for 3 years, 3 times a week, that's not going to help them. And it's not my job to convert them.
Mm.
If that's what you're going to do, I'm not going to talk you out of it. I disagree with you. And I
Mm.
certainly hope you don't start your work that way and assume everybody needs 3 times a week, 3 years, because that's not okay.
Mm.
But it is 100% true that some of the things that we do that are more brief are not the right modality for everybody.
Mm.
Medical folks, same thing. There's your third who are jumping on it, like, "Oh my gosh, thank God you're here. You are you're the jelly to my peanut butter." And then you got a third who needs some kind of massaging and some help who are like, "Oh, now I get it," through those
Mm.
critical incidents. And then you got a third who are just like, "Nope, not
Mm.
doing it." They're not they don't the biopsychosocial approach, what's that?
Mm.
And so you have to kind of meet people where they are, whether it's clinically or collaboratively,
Mm.
figure out what's gonna get them to be more open, more able to move. And my dog's gonna start barking. If you see me looking over,
So,
it's 'cause
Oh,
it's a
no
very
worries.
needy dog, and she's right next to me looking at me like, "Why are you not paying attention to me?"
so
So I don't know, Susan, does that ring for you?
yeah, no, definitely. I would say two other things. So the original question was about, what do you do with your students who suddenly hit, like they're on the moon in primary care? And so I think there are two things. One is to frame all the many really excellent skills that they've learned in graduate school as part of their tools, and to frame what we're going to add to that as really systems thinking as the toolbox. Now, here's your toolbox. It's systemic thinking. We're going to teach you how to do that, how one relationship affects another and affects your outcomes. And you choose the tools you're going to use within that larger systems assessment. So that's about how to honor the many good things that people learn in graduate school, though I wish they learned some of this other stuff too. But the second thing is, especially if they haven't had it in graduate school, is to really give them time to learn about the context. So, I was an anthropology major in college, and I say, okay, now you're going to be an anthropologist. I want you to shadow this physician. I want you to sit in this meeting. I want you to see how people talk, what they care about, what seems to drive this system. Where are the gaps that you think you can make a contribution? What do you not understand? Let's talk about the culture. And each department, each discipline has its own culture. Psychology has its culture, and family therapy has its culture. And that has to be taken into account. And so, and make relationships with people, because I think when it's hard in that, first year or so, certainly the first 6 months, when people feel de-skilled, getting to know the residents, the staff, the physicians is exciting, and the people are smart and interesting. And lots of times I think the relationships can help demystify and develop what's going to become their integrated care selves. So those are my thoughts about the early period.
I love that word that you said, de-skilled. And the other thing that I feel like, what a awesome display of like a systems approach, and my mind would say like a contextual approach or a contextual training method of allowing someone to be like, hey, immerse yourself within this context. And then figuring out like, how would I help this context? Like almost like repeating that every year with new trainees. Because what do Bridget, we have the saying, people don't fight their own ideas, right? So it's a lot better that someone just comes to it on their own naturally. It's like, oh, this is how I could help them, rather than me just being like, this is what you need to do, when it's like their automatic relational frames are going to fight against that because like, that doesn't make sense. I don't get it. But you allowing them to actually experience that moment and come with their own
Doesn't work
ideas.
with students any better than with patients or physicians,
Exactly.
We're all human beings. We don't work that way.
Well said.
And that's the respectful curiosity piece, Another thing I do, and thank you for reorienting us back to the question, Susan, but I use the PPAQ with students. So I'll have them fill it out and say, so which of these things are you doing? And they very quickly realize, oh, there's all these other things that I can do as a student. I'm really clear with them. You're not a change agent in your system. The system is what the system is. You don't have power, but you can observe it, right? Observe what people are and are not doing that aligns with an integrated way of practicing. And if you try some of these things with your supervisor's permission, of course, you might find that things go differently. So for example, seeking out joint appointments and warm handoffs, not hanging out in your office when you're not seeing patients. I mean, that's their comfort zone, right? Like who doesn't want to go hang out in their office and maybe like read some stuff you didn't read for class, So we do that early on, and along with all the things Susan just said, and then we do it later in the year. And I try to talk to my students about, you're going to spend a year in a primary care environment. You could choose to practice like a specialty based person and learn a little, or you can try to practice like somebody who works in primary care and learn a lot. And why would you do this if you're not going to like do the primary care thing for a year? Especially, I think, in the doctoral training, it's broad and general training. Everything is a toe dip. And so I say to them, you're just dipping your toe in this water. You might find that you love this. And I would say about 70% of the students who do primary care-based practicums go on to do internship, postdoc, and so on with some primary care element. Most of them love it. And some of them are like, nope, not for me. And that's okay.
That's
now
great.
Right?
Correct.
So we talk about all this, like every week we have a check-in where we talk about how's it going. We talk about consultation. We talk about creating relationships. We talk about providers who don't want to give you the time of day. We talk about health behavior change, which is another great foot in the door kind of thing. We talk about chart review. How do you case find? How do you figure out?
Mm,
Because when we wait for the medical providers to be the one to identify the situation, so many opportunities to be helpful get lost. And so instead, it's like, hey, your patient has a hemoglobin A1C of like 13. You think maybe I could be helpful to you today? And some students just can't get there. It's just too intimidating for them. But a lot of them, back to, Susan said earlier, like they're kind of maybe a little overconfident sometimes, and that serves them well.
mm.
Sometimes they're like, I know how to do this. I have this new hammer and I'm going to go find a nail. And you know what? That's okay. Um, and I,
Well, sometimes.
well, I was just going to say, we have fantastic on-site supervisors who are there to mitigate
Well,
whatever shenanigans I start. They're the one to like put the brakes on if needed.
we
But
had a new graduate recently who really irritated the chair of the department by, and our chair has had a few years of family therapy training. She's a family doc, but this person gave a discourse to her about behavioral health, how you really do integrated care. It went on for quite a bit, and she went right to my office, and whoa, she was like, this person is so arrogant. They have no idea what they're talking about. I'm the chair. They don't know what my training is.
yeah.
I mean, this person knows way more about integrated care. The other person had been here, they'd had a practicum placement in their graduate program at the VA, which is fantastic training, but very different than an
Right.
academic health center. And this person was holding forth on what we ought to be doing. She was not pleased.
Susan, I love both of you have said so much about it reflects this like humble curiosity that needs to be part of a mainstay of every single thing that we're approaching a system, because all of us that have trained students and definitely interns and fellows, and grace, love, and compassion, everybody's just really excited and they want to show what they know.
I was
Right. It's like, Susan, I think back to my initial days, especially within my fellowship, that I had to seem, I'm like embarrassed by it, right? Like,
No,
it's
I
like,
know.
oh my God.
When I was junior faculty, it's amazing. I'm still here. It was,
Yeah, right. That's how I feel too. Bridget and I, we joke about that. How did everybody not hate us? How did, and so I think that is a really, really big thing and a reminder about that curiosity. I just really appreciate it. Yeah, Nancy, anyone else your mind was
Well,
going
so
to?
the other thing I want to say about this is I think some of that emanates from insecurity, obviously, we know that, and also from a fear of biases, right? Like, I'm going to tell you how great this is.
Correct.
And it's akin to mansplaining, it's behavioral health splaining. Like, nobody wants to be splained
Woo!
to, I mean, nobody
Woo!
wants that. And
well,
so,
especially if they know stuff.
well, that's the point, right?
Yeah.
So I think that sometimes people can go in kind of guns a-blazing, like, I'm gonna tell you how this should be done, and it goes over like a lead balloon as it would if someone did that to us. And what's funny about it is my students tell me all the time about how these medical people are gonna be, telling me how to do things and blah blah blah. Little do they know a savvy medical provider is like, "Oh, thank God you're here, because this is
Correct.
gonna make my day easier, and I am under the gun to see 10,000 people, and so if I can hand off one of these folks or 3 of these folks to you in the course of a day, I can get through my day, get my notes done, and maybe be home in time for dinner." And so I think that I think that's where the shadowing and the all that really comes in, and it's relationship development.
Right.
Um, it really is getting to know the other people as human beings. That's why I love co-training. I will say this. I think when
Mm,
a behavioral health trainee of whatever stripe goes into a residency program, I
amen.
mean, it's amazing because all the learners want to learn from each other because they don't want the faculty to know they don't know what they're doing. So they'll go to another learner and ask questions they would never ask of a faculty member. And my learners also just benefit so much from things like there really are huddles. There's a precepting room. There's places of co-learning. So, if I ran the world, and my joke has been that integrated primary care, total world domination is my life's goal. But um, you know, everyone just needs to be training together.
Mm,
And that's why these grants that we have to do co-training, for my students in psychology that are now co-training with clinical mental health counseling and couples and family therapy, as well as, residents in various different aspects are just they're getting their mind blown a little bit, which is kind of the point, right?
Well,
It really takes a paradigm.
it's how to develop a shared mental model. And if it can happen in training, fantastic. One of the things that I am real proud of but I think probably few people know about, when I was APA president, we had a task force of the few people across the country who were doing interprofessional education and training at the graduate level early on, like not just waiting until you're an intern and finally you think about it, but really co-teaching. So a medical and a behavioral health person co-teaching. And there's so many things we teach separately, but why? Like epidemiology, collaboration, what each discipline's good for, team science, like a course where we learn it together and it's taught collaboratively.
And throw in population health, because I think
population health. Yeah.
That's got to be
having it first or second year in graduate school so that you early on, you can develop, it's like you don't have to do identity and then intimacy. You can do like, be proud of your discipline, learn about it, teach it to the other person, and learn how you're going to work together rather than go 6 years and then suddenly you're supposed to figure out and you're all upset because people don't know what a psychologist does. Meanwhile, social work, nursing, they've all been educating and training together. They know what each other's good for. And then we come along and we're kind of irritated that people don't know how great we are. It's,
Susan,
anyway.
you get me hyped right now. I can see the passion too, that this is the stuff that I couldn't agree more with. And Nancy, I think you were saying something that really, did you just come up with the BH explaining? Like mansplaining, did you just come up with that, or is that something you had already? Oh my gosh, I'm using that so much. We love BH explaining for sure. But this idea of us all working together, integrating, and particularly during the formative years, and it's so funny, Nancy, as you were saying, my mind was just going about how much like we love coming in and being like primary care, do this, do that, rather than us being like, holy hell, you know what, primary care, they serve a shit ton of people. Like they are pretty well respected within the community. Like, behavioral health, maybe we could learn a lot.
They see most of the mental health problems,
Exactly.
not us. So
not us.
Come on.
I say to my students, you have to always remember that medical provider may have actually brought that patient into this world. So how dare you
generations
and tell them about that person? And I also say to them, this is about water on a stone, and in every way, right? Things don't change quickly, right? Things take time. People have to come to it in their own way, as you said earlier, David. And I think that part of what we're trying to teach students how to do, whether it's clinically or implementation, is kind of lying in wait for that critical incident, lying in wait for that moment of opportunity to show. Don't tell people what you're good at, show them what you're good at. Make their life easier, right?
Right.
And I think that
their life easier. You're
end
damn
of story.
right.
You do that, you are good to go.
Well, it will also make your life more interesting. So it works both ways. Seriously.
Oh, Susan, so it's not even just make their life, it will make your life, coming up with some good quotes here.
It works for everybody.
I know we're getting a little bit up to time, and I know we could stay on a little bit longer. The one question I did want to really ask you all, and you do such a good job, I think, of discussing this in the book. And I will say, this is some vulnerability on my end. I will say, man, Nancy, we were talking about things that we say on camera, we're not going to say on camera. This is one that I always have not said on camera, but I'm going to say it. I'll be vulnerable with this. I've always struggled a lot of times with some of because I don't know. I have it. I mean, I'm, infiltrating in functional contextualism, and it's my jam. And obviously there's a lot of similarities with the systems and different things. The thing I've always struggled with, though, is the application of maybe kind of a family systems approach within primary care. Sometimes I go to conferences, I attend presentations, and they talk about the intervention, and usually it's like an hour-long thing that it's like the coming. I'm just like, as soon as I hear, I was like, I check out. My mind just checks out. I was like, that's not going to work in primary care. You're going to see the same amount of people that you would know even if you weren't in primary care. So my mind goes like, is there anything you can say to me? And again, your book did a really good job, but even other viewers that have almost that same relational frame, when we start to hear like family systems, that we don't check out, because it's like, no, like this shit can work in primary care. This is, and not just a theoretical understanding, but the way of approaching patients and visits. Anything that your minds go to that would just be helpful to tear down and erode some of those relational frames that are built on not actual evidence. It's built off of, derived experiences. Where does your minds go?
In fear.
So I can start, because that, I think I had a big dose of that when I started in family medicine. I worked with Tom Campbell for many decades, actually. And I was the family systems psychological science theoretical person who wanted things to be able to generalize. And he was like, nope, how long is this going to take? This has to be practical. Not that interested in that. And
Yes.
so the first project that we worked on together was a curriculum for family medicine residents that was practical, based on family systems principles, because we believed that was the approach to biopsychosocial medicine. And so if you have a chance to look at family-oriented primary care, which is the book that is our curriculum and that we use, we have a second edition that we use for our family medicine residents. It's highly practical. And it, we talk about, usually there's a family member in the waiting room who's underutilized. And that the truth is, if good studies show patients do less than 50% of what physicians tell them to, why is that? The answer is their grandmother doesn't agree. They can't afford it. They, et cetera, et cetera. If you have somebody that is actually the primary caretaker who's in their natural support system, who's part of the healthcare team, the chances they're going to control their diabetes just goes way up higher. Yeah. And it's not a matter of, the studies about how long is an interview, a biomedical interview versus a biopsychosocial interview that we did in the 90s, that we, meaning actually some internist colleagues of mine and Ron Epstein, showed that at that time, the average primary care interview for a patient from a biomedical point of view was 15 minutes. How long was a biopsychosocial interview? What's the average? It was 16 minutes. Why? Because you just use your time differently. Amen. Amen. You don't go about otitis media for way longer than a patient needs to hear. And it's the same if you have a family member in the visit. Your first reaction can be, I don't have time for that. It totally depends on how you use your time, and trying to be effective and practical about whether the patient's going to provide all the information you need and be able to carry out the treatment plan that your evidence base tells you is going to help with their ear infection or their diabetes or their colon cancer or whatever it is. So I do think it takes us translating the way we think into Amen. A practical primary care, 8-minute, 10-minute, 15-minute session, and being able to think like that. So I would offer, because Tom, when we wrote family-oriented primary care, just hammered me about it. And I hammered him about, but there has to be some concept so that this patient isn't different than this one, isn't different than that one. So that's my answer.
That was great. So Nancy, where's your mind go?
So it's funny. It made me reflect on coming into University of Rochester, newly minted PhD in child clinical psychology, with no family therapy knowledge. And, I was kind of comfortable doing parent counseling, but that idea of talking to more than one person at once, kind of terrified me. So the idea that I would like walk out to the waiting room and pull in a family member or pull in somebody on Zoom, for example, now that we have that wonderful opportunity, vaguely terrified me. And similarly, I was like, so even as I'm learning, quote, family therapy skills in that hour-long kind of modality, how do I take those discrete elements and bring them into primary care? And I think FOPC does that really beautifully. That was part of what helped me. I had the benefit of working with Susan, Barbara Gawinski. To this day, whenever I really want to talk too much, which is all the time, I like rub my thumb, because that's what Barbara Gawinski told me to do. Rub your thumb, ground yourself, shut up, You know what I'm saying? Let the family do
Stick
their
your thumb in
thing.
your mouth.
Yeah, exactly. Yeah. Anyway, and so I think there's a lot of fear, and that's why I said that earlier. I think that there's a lot of like one-on-one, I can barely get out of here in 15 minutes. You're gonna add another person?
Amen.
Hell no, you know? So I think that we've really got to help people see how that other person is like the key that unlocks the door.
That's why live supervision for
Yeah.
residents and for behavioral health people is really
Yep.
important. Because
Yep.
just thinking about it in your head doesn't work.
Doesn't work.
You know, so
Amen.
we have the residents bring in patients and their natural support system, and we're behind the mirror, and they have to do an interview that either assesses the dynamics or focuses on their diabetes or something, so that it gives them some skills and they start to see it as interesting and an advantage rather than scary and overwhelming. So we
Which is
have enough training time in the residency, but we have to do it on the behavioral health side too,
right.
or, you know, it's scary.
I just want to kind of make something covert overt. So Susan, you were talking about getting medical folks to go from a biomedical to a biopsychosocial and how you kind of had to get them kicking and screaming. And then once they learned how to do it, they're like, oh my God, this is so much better, which has been my
Mm.
experience. It's like, I didn't know what I was missing, right?
Mm.
And the things I was missing were the keys to helping this person do what they need to do, right? I think similarly,
Mm.
individually trained behavioral health clinicians kick and scream when you try to get
Amen.
them to think about relational family therapy, dynamics in a family, and even things like family scripts around, sorry, my phone of course just went off. Family scripts around illness, right? If I
Mm.
don't understand what diabetes means to this person
Amen.
based on what they've seen happen in their family, how the heck am I supposed to help them? Because they've already got a written story,
Nancy,
right?
I had a patient, I tell this story all the time where uncontrolled diabetes, and I went in and I was doing the contextual interview, and she had mentioned her father passed away. And again, curiously, it's like, oh, what caused your father to pass away? Died for complications from diabetes, which again, usually what that turns into is like, oh, this is great. I can use that to increase this person's like agency. And it's like, oh, you don't want to be like that. And what it was though, was her belief that it's like, hey, my diabetes is a death sentence. Why would I care about taking any medication or doing anything like
Doesn't
that?
matter what I do.
It doesn't matter what I do, right? It's like,
Yeah.
oh my gosh. And again, if you don't have that nugget, I can go there, do motivation interviewing for days, and that person's not going to come out any motivated, more motivated to, because as you
Exactly.
said, there was a key part that was missing that we wouldn't have known.
It's a jigsaw puzzle, right?
Yeah,
And
well
so,
said.
it's great if you can do the corners and the edges, but if you don't fill in the story and you don't thicken the narrative and you don't understand relational context, so why do people not do what they're supposed to do? Susan mentioned money. Susan mentioned somebody else in the family kowtowing it. Maybe this person is so overwhelmed because they have absolutely no social support that the idea of even getting to the pharmacy is like, what do you create? I mean, right? So I feel like, you talk about contextual interview. I also think that helping people another big life experience for me, and I know we're trying to wrap up here, but, while I was going through my family therapy training, and I happened to work with this woman who wrote the book Medical Family Therapy, so there was no pressure there at all. But, my mother was going through a heart transplant,
Hmm.
and I vividly remember so many things that happened in my family around how our interactions changed, how our family changed from the experience of
Hmm.
illness. That idea of like, so it was, any family who's gone through a serious medical thing will tell you it changed them. And one of the stories I tell my students all the time is my mother was visiting my sister in Colorado. Well, oxygen was an issue for her. She was in Colorado. My sister looks over, her lips are blue. She
Hmm.
My sister's like, "Let's go to the ED." She's like, "No, I'm fine. Like this is nothing." She used to go to the ICU and not even tell us she was in the ICU because it
Hmm.
became normal.
Hmm.
And I had the benefit of literally being taught about medical family therapy at the time to be able to understand that and work with it and not be so devastated by it.
Hmm.
But most people don't have that. Most people don't have the ability to say, "Hey, mom, I know at this point it feels like no big deal when you go to the ICU because it's happening every 3 months, but I really want to know."
Amen.
And so
Hmm.
I think that we forget that it is all relational, whether
It
it's
is
between
all relational.
right? And so anybody who's been through those experiences, and I invite anyone who's watching this, like ask yourself, if someone I loved was going through a serious medical issue or even a chronic condition that wasn't being well controlled, wouldn't I want to have the opportunity to be
Oh
part of
yeah.
the solution? And yet we cut people out, you know? So I hope that people really
Well
think
said.
about that. Get over your fear. It's not that big a deal. You get the other
And
person in the room. Maybe you have to interrupt a little more. We're all good at interrupting. Um, and I
I
think it transforms the clinical work, and then thinking systemically transforms implementation. So hopefully
as
people improve on that.
as always with these PCBH corridors, it's honestly, this is the thing that's so funny. It's funny that it's rippled out in the way, because this was actually just a selfish way for myself to talk to people, to be educated and stuff. So I have so much gratitude for today. I know we could talk for days about these topics, but my appreciation for not only coming on, but for the book, the decades of service and work, and then also just for making it, again, doable and still honoring the complexity that working in integrated primary care can be. I just have so much gratitude. And Susan, I want to give you a shout out too. I was talking to Stacey Obide at CFHA. And somehow I forget. It's fun when you learn that you're a part of someone's conversation. I think you were at CFHA, right? You were at Phoenix. Yeah, I think you walked by. I was like, I have never. I said to Stacey, I was like, I've never talked to Susan, And Stacey's like, oh my God, she's great. She's like, I was at a conference the one time, and I So I just want to express for both of you, for the number of students and the number of people in the field that you have inspired, and being so gracious with your time. Thank you for that, because I know that means the world to a lot of different people. So,
Well,
I also just want to say that Susan has mentored countless people, and including me. And
mhm.
part of the reason we wrote this book, for me, and I'll probably get a little emotional as I say this, but
Hell
like,
yeah,
you know, look, I wanted something that almost documented
hell yeah.
how we've worked together for 30 plus years, and how my life has been made better in my career from having Susan as a mentor. So many opportunities came my way that I know wouldn't have otherwise. And so I think one other takeaway I hope is, if you don't have a mentor, go find one. And if
Amen.
you're in a position to mentor, look for someone to mentor. People are always scared to ask, and it's the most generative, wonderful thing.
right.
I'm
It
mentoring
makes
people. It just pass it on,
great.
man,
It's a
and so
selfish thing to do.
I like that. I like it. We're
you
gonna
learn
end
so
on.
much.
Yeah, you're damn right. You're damn right. Well, again, thank you so much. For people that are watching, obviously, send emails, ask questions, keep the conversation going. I have a lot of gratitude for you all. So, thank you
Thank
for
you,
joining
David.
today. I
Yeah,
Thank you.
appreciate it.
This
All
is
right,
such a
yeah,
great way to get information out to people. So
yeah.
really
we try.
appreciate
Really
you for
appreciate
helping
it.
us, and hopefully, and appreciate you talking up the book, because
Yeah.
you do something like this and you just hope people read it and get something from it. So
And
I thank
the
you for
book will
that.
be in the description, in the video
Great.
below as well. So, all right,
Oh,
take
Thanks
good.
care,
so
y'all.
much.
Bye-bye.
Take care.
Thanks so
Bye,
much.
Nancy.
Bye-bye.